All right, perfect. Well, thanks everyone for joining. My name is Joshua Marcus. I'm a neurosurgeon at Elite Brain and Spine of Connecticut, part of Newvan's Health in Southwestern Connecticut. Just a little bit sort of about myself. I am a neurosurgeon. I graduated from NYU in 2009 from NYU School of Medicine, did a residency and subsequent fellow in New York, and practiced primarily at trauma hospitals, again in Southwestern Connecticut, treating both spine and cranial disease. My practice is primarily focused on spine. I do a portion of my practice dedicated to endovascular stroke and vascular diseases of the brain and spine, and some brain tumor surgery, brain trauma surgery as well. My personal interest has really been in novel technology. My practice specifically was the first to perform mechanical thrombectomies for stroke in our area, some endoscopic intracranial bleeding evacuations, and the first facet arthroplasty in Connecticut, which we will talk about, spine joint replacement, and how that relates to spinal stenosis specifically. When we think about neck and back problems, which are extremely common among Americans, specifically, they can be treated by a variety of providers, right? Very often patients are seen by their primary care doctor. They can see their chiropractor. Sometimes they're seen by a physical therapist, a neurologist even, a physiatrist. Orthopedic and neurosurgeons are spine surgery specific doctors who treat all sorts of neck and back conditions, pain management doctor, acupuncturists, and very often all of these providers are kind of interfacing together. Sometimes patients are seeing some or all or a few of these different providers. But really the pathway to treatment for back pain and spinal stenosis can go through any of these providers specifically. We'll talk about managing back and leg pain, what the difference is between back pain and radiating leg pain and sciatica, and how surgery plays a role in that specifically, and what some of the newer technologies allow us to do to treat these conditions. So low back pain is one of the most common conditions that patients will see a medical provider for. One of the most common conditions and causes of missed work among Americans, and affects tens of millions of Americans each year. And that is what is called acute back pain, where it kind of comes on spontaneously and never happened before, can certainly go away as fast as it comes about, or chronic back pain, which many millions of Americans suffer from on an everyday basis. And there's a variety of sources for that pain that we'll talk about. But acute discogenic pain is that, I was doing fine, bent over, put something in the sink, went to brush my teeth, twisted wrong, and then this horrible sort of incapacitating back pain develops. It's not typically associated with what we call red flags, right? Weakness in your legs, numbness in your legs, any sort of bowel and bladder trouble or accidents. Those are more urgent findings that really need to be seen by a medical provider immediately. But because the pain is so bad, patients will often go to the emergency room. It feels like there's just something terrible going on, and there is clinically. But the vast majority of these will really get better over time. Conservative treatment is our mainstay for this type of pain, which really comes from either a tear in the disc itself, which is the shock absorber between the bones of the spine, or some inflammation in that area. We'll treat them with anti-inflammatory medications, muscle relaxants, ice, rest. And often in days, these symptoms go away. Sometimes takes longer, sometimes takes weeks, and in certain instances can turn into a more chronic back pain condition. Leg symptoms are what we'll talk a little more about. Those are more concerning for more serious conditions of the lumbar spine, but they can start after an acute back pain episode. And these are important to recognize. When the symptoms move from the back and start going into one leg or both legs, or are associated with weakness, numbness, tingling, or any other sort of deficits, we become more concerned and sort of more vigilant about potentially getting imaging, right? Whether that be X-rays, a CAT scan, or an MRI. The frequency and length of these episodes are pretty important, right? If they're happening more often, something that needs to be evaluated sooner. Sometimes they are few and far between. Sometimes it happens once and then never again. When we talk about spinal stenosis, that is a more chronic condition, often resulting from a narrowing of the spinal canal. Can you see my cursor here? Perfect. This is what we call a sagittal, as if we sort of cut you sort of straight down the middle like this. These are the bones of the spine. These are the discs, the shock absorbers. They normally look pretty healthy and white with fluid. Over time, they kind of dry out and look darker, and sometimes they even flatten over time. But the spinal canal, which is this sort of white tube, the white represents our normal fluid called cerebrospinal fluid, can get narrowed. And you see it sort of severely narrowing here, and the nerves can get compressed or squeezed or narrowed. Often that results from joint overgrowth. The same as I tell patients, if you get arthritis in your hands and you see your joints swelling out of your skin, that can happen in your spine. Joints are living tissue, and as they grow and become arthritic, they don't swell in a visible way or enlarge in a visible way. They enlarge into the spinal canal, and that can cause spinal stenosis in the facet joints themselves, which are the joints that help the spine cord flex up and down, and the ligament that sits in between them grow and compress the spinal canal. These symptoms, or spinal stenosis, can result in a clinical condition we call neurogenic claudication. So more than back pain that comes across the back, this can develop buttock and leg symptoms, specifically when you're standing and walking. So if you have symptoms in your back that then become symptoms that go into the buttocks, down the legs, often they're equal in both sides, but they don't have to be. That get better when patients are flexed forward. Sometimes patients will notice, I'm in the supermarket, I'm leaned over a shopping cart, my symptoms are better. Because what's happening is this, as the spine flexes forward, it kind of opens up a little bit. And when you stand upright, the spine sort of closes itself, and extension can make these symptoms much worse. Extension meaning standing upright, flexing meaning bending forward. Often, again, the treatment paradigm involves anti-inflammatories, physical therapy, chiropractic care, epidural steroid injections, which can be quite helpful. But it's very important that in patients where your buttock and leg symptoms are the primary feature, that is a potential candidate for surgical intervention. And again, surgery is and should be the last resort for most patients. But as patients sort of go through that treatment paradigm here on the bottom left here, surgery becomes an ultimate option. And because this is a compressive problem, surgery is a good option because we are attempting to decompress the spinal canal. When it is back pain alone without those buttock and leg symptoms, surgery is a less clear potential benefit for patients. And what that surgery involves is opening up the spinal canal with what's called a laminectomy. We take off the back parts. These are the facet joints. This is the lamina and the spinous process, those bumps you feel in the middle of your back. And surgery is meant to decompress that area of the spine and give the spinal canal more room to breathe, which is what's called a laminectomy, or removing the lamina. And it can be done at one or multiple levels of the spine, and sometimes requires fusion or stabilization. And we'll talk about sort of what those indications are, but that's typically done with hardware, right? That's where patients are getting rods or screws or cages or spacers to stabilize the spine and ultimately fuse those bones together, taking away some of that motion. And so what a fusion does is it essentially makes two bones, or sometimes multiple bones, grow together over time, making it more rigid. Stenosis can often be seen in the setting of what's called a spondylolisthesis. The bones of the spine stack like boxes. When one box is sort of moved on the other box like that, that is called the spondylolisthesis, and the joints that hold the spine together in the back become incompetent or fail. It's a progressive degenerative problem that often associates with spinal stenosis. As you can imagine, if the spinal canal sort of travels between, almost like a cigar cutter, if one bone shifts on another bone, the canal becomes smaller and smaller, and stenosis symptoms can develop. This is a degenerative process that develops over time, but is really centered on these joints that sit on the back of the spine that can lead to progressive stenosis and what is called that claudication pattern of pain. Back pain can develop in spondylolisthesis as well, and that pain can be due to disc degeneration, the shock absorbers sort of failing, facet degeneration, those joints failing in the back, leading to spondylolisthesis, or chronic nerve root irritation. And these are the patients that ultimately wind up getting a fusion with their laminectomy for a variety of reasons, but the main one being, if you are freeing up the spinal canal, but the boxes, the bones of the spine are moving, you have to do something to stabilize those bones. And what we have had for the last many decades has been to fuse the bones together, first with patient's own bone graft coming from the hip, and now over time with rods and screws and cages. Conservative treatment is really our first line treatment, directed at symptomatic relief, right? Rest, anti-inflammatory agents, physical therapy, primarily with flexion exercises. We want to avoid all of that extension exercise that's going to make the spinal canal more narrow, and we want to work on flexion exercises and hamstring stretching. Again, surgical treatment is to free up the spinal canal, decompress the spinal canal, but in that setting of that spondylolisthesis, very often patients undergo what's called a fusion. And they're recommended to undergo a fusion because you don't want the bones to further shift in a way that could lead to more instability, could put more stress on the disc, could put more stress on whatever element of the joints are left. And in addition to the decompression, a fusion has become the mainstay treatment and has been the mainstay treatment for the last, again, several decades in this particular pathology. I wanted to just quickly talk about a few back pain generators so that, as we get into spinal stenosis specifically, we sort of talk about what makes that different than back pain, right? And facet pain is pain that originates from the facet joints. These are these areas here. It's one bone connecting to the other bone behind the spinal canal. That pain is often on both sides, kind of a bracket across the low back. Is a little more vague, not as clear in the buttock, not as clear in the legs. Also better when flexed forward because the joints are under a little less stress, worse with extension. And again, the conservative treatments are really the mainstay, if not the only treatment for this type of pain. Again, avoiding extension. There are certain injections patients undergo. If anyone's undergone what are called branch blocks or radiofrequency ablation, these are really centered at the nerves that go to the facet joint that are eliciting some of that pain, as opposed to what we described before, which is the spinal canal being narrowed, causing that nerve pain specifically. So we talked about fusion being the sort of long-term mainstay treatment. And I wanted to kind of pivot into newer technology and where we are in terms of spinal stenosis and spondylolisthesis, and talk specifically about the TOPS device and this surgery in detail. We talked about taking two bones, decompressing them, and stabilizing them, right, turning them into one solid piece of bone. But newer technology allows us to do that decompression actually widely, taking all of the joint, all of the ligament, and freeing up all of the nerves in the spine, but placing a posterior element joint replacement. So when those facet joints come off the back of the spine, we are able to place a facet joint replacement device that is pedicle screw based. You sort of see, these 4 screws that go into the bones, 2 in the bone above, 1 in the bone below, and connect with a device that allows for motion, right? As opposed to a fusion, which is motion, which takes away all of the motion. This is a newly FDA-approved device as an alternative to lumbar fusion, which we have seen with great success recently. And what that does long-term, right, allows us to do a very wide decompression, has shown good postoperative outcomes and superior postoperative outcomes compared to fusion. But also, you can imagine if each level of your spine works as a sort of cog in a line, in an assembly line, and you take one of those motion segments away, all of the other segments have to work harder. And so what happens is over time, patients develop what's called adjacent segment disease, right? The other levels of the spine break down. Either the disc breaks down faster, the joints break down faster, stenosis develops above or below the fusion. And preserving motion, right, allows that stress to, again, be centered over all of the levels of the lumbar spine symmetrically. Again, this is the device specifically, which allows for both lateral bending up to 5 degrees. You can see flexion and extension preserved, and some axial rotation, right, allowing patients to kind of twist. And even though the joints are missing in each of these areas because they've been decompressed, this serves as a replacement to those joints, similar to how these joints are going to function above and these joints are going to function below. And so what that allows us to do is preserve the stress across the spine specifically, without putting additional stress on the other levels of the spine. And similar to a fusion, the goal is really to decompress the spinal canal, right? That's the sort of mainstay treatment here. You want to alleviate those symptoms going down into the buttock and legs. And you can do that in the setting of a spondylolisthesis, again, where those bones may be shifted, but allow something that's actually going to stabilize the spine, but not going to take away motion. And again, preserving motion in all directions, in all the natural directions of the spinal canal. And again, this is based on a pedicle screw system with screws that go into the bones. We don't have to access the disc or the front parts of the spinal canal, and is all done from what's called a posterior or back approach. And when we look at some of the outcomes for this device, there's a multi-center trial that looked at this over a couple of years, large heterogeneous patient population among neurosurgeons and orthopedic surgeons, private practice, and academic surgeons that really compared this particular procedure to lumbar fusion, to a one-level lumbar fusion. And when we look at a lumbar fusion, which is a procedure we know is the right procedure for some patients, but sometimes wrought with long-term issues for other patients, the overall clinical success at the 2-year mark really favored the TOPS procedure. And you can sort of see, we can look at what that means in all of the different variables, but the TOPS group really demonstrated a meaningful and substantial advantage over the fusion group. And if you look at overall success at 2 years, the fusion population was at 24% and the TOPS procedure patient population was at 77%. And the TOPS system was deemed to be really superior based on this data to fusion control with respect to composite clinical success while maintaining safety, which I think is a critical point here, that this is an equally safe procedure, if not safer, and simultaneously better for patients long-term being 2 years and even more beyond that. And that was really based on who needed additional procedures, right? In the fusion population versus the TOPS population. And again, who had reductions in their pain, right? And the Oswestry index and what is called the VAS back pain index showed superior outcomes for the TOPS patients as compared to the fusion population. And you sort of see the overall success. Again, no major device adverse events, which I think is a pretty critical thing to think about when you're thinking about new technology, right? Safety is really a #1 priority. No new neurologic deficits and increased reduction in pain. Patient-reported outcomes, again, which is based on a pain index. You can see preoperative patient populations were pretty similar. At the 6-week mark, you can kind of see the patient-reported outcomes of pain scores decreasing at a higher degree in the TOPS population, all the way down to the 24-month mark. And this is based on a pain score that is patient-reported. Similar with leg pain, which again was one of the #1 goals of any decompressive operation, especially from a neurosurgical standpoint. You can see improvements in the leg pain score, patient-reported leg pain scores at a superior rate in the TOPS population as compared to the fusion population. Should I answer some questions now before we go into some case study?
Sure. So let me just let me pick one of the questions.
Sure.
Someone asks, what about retrolisthesis? Is this device good for retrolisthesis as well?
So I think it has some benefit, although has been less studied, right? So when we think about what the clinical indications based on this FDA study are in my population, retrolisthesis is less often associated with spinal stenosis in the same way an anterolisthesis is associated. Although I will say in patients where that retrolisthesis is mobile, there's potential benefit here, but has been less studied specifically.
Another
Yep.
question came up is, what about the L5-S1 segment? Is that a segment that can be treated with TOPS?
So that's a good question, because often that is a common source of spondylolisthesis. The typical pathology for that spondylolisthesis is very different. It is less so the facet joints decompensate. Very often it is associated with a defect in what's called the pars interarticularis, and very often it's associated with